Mic test, 1, 2. Mayong gabi, CMU. I am Jeff Granada, and this is my partner, John Kevin Bakir. And in tonight's case presentation, we are going to be discussing the pathological progression of chronic kidney disease in a 3-year-old English Bulldog. So, our patient is a 3-year-old canine. He is an intact male English Bulldog, weighing at 30.8 kilograms. So his history actually is he is a house companion dog, and at the same time with updated vaccinations, complete dewormers, and a diet mainly consisting of table food. So the first thing that happened was on March of 2024, and the patient actually went to the clinic for a routine annual checkup in which the physical examination resulted with no signs of disease. A complete blood count was also accounted for with a slight monocytosis. However, the serum biochemistry resulted in an increase in the serum creatinine level at 3.3 mg per dl within the normal range is only 0.5 to 1.8. So the attending veterinarian actually prescribed a renal care diet and at the same time renal supplements in order for us to check if the increase in the creatinine levels was based on the diet or other kinds of problems. So again, on April 16 and April 30, the following checks also resulted with an increase in creatinine levels, and so therefore on May 18, more diagnostic tests was done. So first is urinalysis, in which there was presence of leukocytes, presence of protein, and an acidic urine acid, and also radiographs were also conducted, in which it also resulted with mineral opacities. Blood chemistry also resulted with an increased level of SDMA and at the same time creatinine levels. On May 25, another urinalysis test was actually conducted in which it resulted with an increase in protein to creatinine ratio. On May 31 until August 6, there were actually 3 main tests that were conducted with the patient, which was the blood chemistry, the X-ray, and at the same time, the urinalysis. So they actually all resulted with 4 similar kinds of results, which is the increase in creatinine levels, the persistence of our mineral opacities, the presence of leukocytes, and at the same time, an acidic urine. Next is September 18, which is actually our one of the first highlight symptoms in this case because of anemia. So a full complete blood count was actually done in which it resulted with anemia and at the same time a slight monocytosis. September 21, October 8, and November 5, another CBC was actually conducted in which there is a decrease in our RBC count and also resulted in anemia. So again, on November 19, the continuation of the monitoring of our creatinine as well as our X-ray radiographs were conducted, and on November 22, a complete blood count was actually done in which the given medications was increased the RBC count for this case. On December 9, another highlight case was presented, which was an increase in the blood pressure and blood chemistry for the SDMA and creatinine levels also again were increased. December 20, December 27, and December 28, the veterinarian actually prescribed ACE inhibitors such as our enalapril and then further changed into the minazapril. And on January 9, the blood pressure actually decreased and the CBC, SDMA, and CREA was still slightly increased. So this is the graph for our creatinine levels in which it started on March 12, 2024 with a 3.3 mg per dl and ended up with 4.3 mg per dl. So as you can see in the graph that was presented here, there is a slight gradual increase or progression of our creatinine levels. Next is our RBC and at the same time our platelet counts in which there is a gradual decrease specifically here on September 18, November 7, and eventually came back to the normal results in November 22 because of the given medications, which was erythropoietin alpha. Platelet counts was also within the normal range, spiking up and down, and there is again progression towards the higher end. HCT and also the HEB showed similar results when it comes to the graphs, as this again is related with the anemia symptoms that happened on September 18. So these are the main findings when it comes to our urine analysis. There is a presence of our leukocytes, a presence of our proteins, presence of our microalbumin, our ascorbic acid, calcium, and an increase in the protein to creatinine ratio. And we just want to mention and highlight that, again, this is an increase in the creatinine levels. So this was actually the first radiograph that was documented, in which this is the lateral view, in which you can see the urinary bladder. There are actually mineral opacities that can be found during this, and the kidneys are actually normal in size. So the following radiographs, although given with renal supplementations, there is still the persistence of the mineral opacities in this case. Now for the differential diagnosis, I pass the mic to my partner.
Thank you for that, Chef. So, as we correlate all the laboratory findings and clinical signs, we can get a better diagnosis. So, in our approach to organize our differential diagnosis, we have compiled a table showing the potential diagnosis. Potential diagnosis, showing the clinical manifestation and indicating a check mark that the patient is experiencing this sign or not. So, without further ado, our first differential diagnosis would be obstructive uropathy via urolithiasis. Of course, this would cause an obstruction in the urinary bladder, and this could lead to a backflow of urine in kidney, leading to enlarged kidneys. But the radiographic image doesn't support this. So we ruled out the first differential diagnosis. Then, for our second one, which is chronic pyelonephritis, we excluded this since the CBC test didn't show elevated signs of WBC, considering that pyelonephritis is a recurrent urinary tract infection. Then, on urinalysis, it didn't even show any presence of blood, pus, and WBC CAS. That is why pyelonephritis is out of the table. Then, that leads us with glomerulonephritis, and then a hallmark of this disease is a persistent proteinuria, which can eventually lead to hypoalbuminemia in the body, causing edema. But physical examination presents no edema. And to further back this up, the urinalysis should show a high creat to protein ratio. Further, all of these differential diagnoses actually show presenting clinical signs upon checkup. However, in the first visit of our patient, he was apparently healthy. Now, with all the clinical findings, the laboratory signs, we can therefore conclude that the most likely diagnosis would be chronic kidney disease. Now, chronic kidney disease is an irreversible condition. It is also a gradual loss of your renal function over an extended time. Actually, as easy as it sounds, it is actually complex to diagnose it. Why? Kidney diseases actually can overlap with one another, or one can be a secondary to another kidney disease. So, with that said, according to the International Renal Interest Society, there must be conditions to be met. So with the first criteria, we should rule out the pre-renal or post-renal causes so that no misdiagnosis can happen, which can lead to inaccurate treatment. And we already done this in our differentials. This can be your bicarbonia. And we can also see, and it's also high in phosphorus and sodium, which can. So now that we have described our diagnosis well, we can now lead to a better comprehensive treatment plan.
So for now, for the treatment plan, the first thing that they did with the attending veterinarian is actually to change the renal care diet, in which we must consider the five major factors, which is water or moisture, a decrease in sodium, a decrease in potassium, a decrease in nitrate, and at the same time, omega-3 fatty acids. So the next drug that they actually used was doxycycline, in which there was an increased leukocyte count in the urinalysis. And potassium citrate was actually used because this alkalinizes the acidic urine that was tested. And renal supplements actually focuses more on breaking down the ureates and at the same time promote renal function. For the erythropoietin alpha and iron, this was actually used as a systemic medications for the anemia. And for benazepril and enalapril, these are ACE inhibitors for the hypertension symptom that was presented with our patient. Lastly is probiotics, and this can actually introduce good microbiota, in which it can also help in the excretion of the waste products in our body. So to summarize everything up, this case is a chronic kidney case in which it was diagnosed during a routine annual checkup, which highlights importance of an early detection, and having an early detection allows us to have better tools, and better tools will also allow us to have a better diagnosis, and having a better diagnosis will lead to a comprehensive management.
Let this also be a reminder of regular veterinary checkups for all pet owners. Imagine what would have been of the patient if it wasn't detected early. You have to think about your choices and the decisions made. It is also vital of what you feed to your patient can actually lead to affect its overall health and health options. So this could also be the difference of its long severity in life or short life expectancy. So now this is our recommendations for this case. It is a full serum chemistry panel with blood gas analysis to see if there are any electrolyte imbalances or abnormalities in the acid-base balance. And then we have to further investigate the mineral opacity seen in the radiographic image to correlate it to your CKD. And then last but not the least is an ultrasound to evaluate both the kidneys, urinary bladder, and parathyroid to see which one is enlarged or which one is short. So this is also our case presentation. My name is John Kevin Sibakir, and this is my partner Jeff. Thank you.
Okay. Start. Ah. Okay. Magandang gabi mga Ginoo. Ako po ay nahihiya sapagkat kayo ay kayak. Char. Naulaw ko kaya nagpaan ako. Sila kay. I'm actually imagining myself in a show, if you are familiar, Shark. Someone is selling to me, I don't know, maybe brand new models of iPhone. Bantay lagi mo po naman. Anyways, okay. First off, I'd like to congratulate you for a very well explained presentation. What I actually like about your case study is that you actually have an outline of like a constant monitoring or like the progression of the case as it went through. You in life, you do not really encounter these types of cases wherein both the veterinarian and the owner are that persistent in monitoring the case. That's actually quite one of the few clients that we wish to actually handle. Yung mga, they do have, well, all of, the pet owners have a level of concern, pero not all actually have the means to like monitor the case, much less one that is as complicated as what you've presented. Okay, so congratulations. I have a few questions. First would be, I'd like to get your thoughts on the reason behind you gave first, the reason behind why you gave doxycycline as an antibiotic, have you actually done some sort of like bacterial cultures to like specifically pinpoint a bacteria that might be treated, or like that might be killed, or that might be controlled by by the drug? And then the second question is, I'm also curious why you use two of the same types of drugs at the same time. That's your ACE inhibitors. Why did you use two drugs instead of just choosing one?
So for the doxycycline, one of our CBC actually has an increase in our leukocytes or our white blood cells, and with that, that's why we administered the doxycycline. And at the same time, this is also used as a prevention of secondary bacterial infections rather. And for your two ACE inhibitors, so actually the attending veterinarian actually used the enalapril on the first symptom when it comes to the hypertension. But however, this was not successful when it comes to lowering down the blood pressure, because enalapril is actually metabolized in the liver. However, because of the chronic kidney disease, this is not excreted through the kidneys. So that is why they actually changed the drug to benazepril, because benazepril is actually metabolized in the liver, and at the same time it is also excreted in the liver. So when it comes to the enalapril ACE inhibitor, this can lead to the drug accumulation, which can affect the drug distribution and also its efficacy when it comes to lowering down the blood pressure of the patient.
Okay. So yeah, again, food for thought. I get that you actually shifted to benazepril because you don't really find enalapril to be that, beneficial to the case. But as to the antibiotic, this is actually, again, you have been blessed by a case where the client is actually able to like monitor the progress. And what I'm saying is, rare cases like this you should actually take advantage of like rare cases like this. My point being, given that the client is able to like shoulder for the constant monitoring, I think should have just taken advantage of like doing urine cultures to like specify yun kung which antibiotic might be suitable to the case. Well, doxycycline actually as an antibiotic is quite useful because it's not that really disintegrated, or like it's not that they're not really affected by the environment of the soft tissues like urine. So they are quite effective in like doing their action with regards to these areas. So yeah, thank you.
Just 5 minutes. I said, still have 5 minutes. Congratulations, gentlemen. This is my on your case presentation. I do appreciate on the clinical pathology aspect you have laboratory test, and with your now with your case, you have a statement here that there is normal evaluation on the following. You mentioned here that different body system, it was normal. What was the test that you did perform? General appearance, cardiovascular, respiratory. I'm looking for that result.
Okay. Actually, Doc, all physical examinations such as our CRT, skin turgor test, and general appearance, and they only find out that the abnormal side is only their weight and again their CBC results. But any other physical examinations all resulted in normal type.
Now you have to be specific what examination you did perform because you mentioned here respiratory, musculoskeletal. So if it's physical examination based on the body system, that's the only one that should be written here because I presume that you did perform other tests ruling out that this was normal for this body system. You have an amylase test. Amylase. What's your interpretation for this based on your result?
Oh,
And how is that related to your final diagnosis?
hello. So, so for that, doc, hello. To remind that the, hello. Well, thank you for that great question, doc. Well, to remind, in the start, the client only came in for an annual wellness checkup. They were actually expecting to find any problems instead of finding out that the serum creatinine was high. And amylase, for the amylase test, it was also just to check if the liver function was normal.
And also in your radiography, you showed mineral opacity. What could be your interpretation of this? Are you not ruling out urolith?
Well, actually, there was a big chance that this is indeed a urolith because this English bulldog it is actually predisposed to calcium oxalate CaOX2, and at the same time there was a presence of calcium in the urinalysis, and the urinalysis also tested slightly acidic, in which it is very prominent when it comes to the formation of our uroliths, and specifically we are guessing that this is calcium oxalate uroliths. And although this cannot be confirmed 100% because no surgical intervention was actually done because a higher risk for brachycephalic dogs is common, this is very highly suggestive that this type of urolith is again calcium oxalates.
You did not perform microscopic examination for urinalysis to determine what specific cast or crystals that could correlate your, if you know the pathophysiology. Yeah.
So for the urinalysis, doc, a microscopic examination was done, but this is the mystery of this case because on examination there wasn't any abnormalities seen upon microscopic examination. That is why we cannot still rule out if it was whether calcium oxalate that is causing it. And that's why we need to further investigate this on other tests.
So actually, there is anemia in this case because again, the chronic kidney disease primarily affects or damages our kidneys, and the kidneys actually produce a natural hormone called the erythropoietin, and this erythropoietin actually is what stimulates the proliferation or the creation of our erythrocytes. So that is why the the veterinarian actually gave out the medication of erythropoietin alpha because this drug actually mimics that natural hormone. And on November 22, it actually came back. The RBC actually came back to normal result.